Good evening, everyone. A warm welcome to this evening's Scan.com webinar. We're going to kick off and get started in just a couple of minutes' time while we wait for everyone to filter in. But we're really pleased to have Mr Shah with us this evening, talking about all things knee imaging in a nice Q&A for you guys. So for those of you who don't know me, hello, my name's Lily. I look after content here at Scan.com. And if we've not, well, we may have indirectly spoken before if you've received one of our newsletters or an invite to this very webinar. So it's great to be here with you this evening. And here is a little bit about Scan.com. So I'm aware that some of you may know who we are and use Scan.com and have come to some of our webinars before. But if you haven't, just for a bit of context as to why we're here, why we're talking about imaging this evening. Scan.com is all about making imaging accessible, and that's not just for you as a referrer, but also for your patients. So as you can see here, we have a portal that's free for you to use that you can refer your patients for MRI, CT, ultrasound, X-ray and more. And you can get started by scanning the QR code, but we'll also follow up with you by email after this session if you've got any questions about what we do. But as you can see from this very fast little demonstration, it's really easy to find the scans that your patients need and refer them, and then you can track the referrals in this portal and also view and download the results digitally. So it's also great for your patients because they get more choice over where they have their scans. So there's over 200 imaging centres that they can choose from. So it's really flexible and gives them a lot of options over their care. So I'm going to stop sharing my screen, and I do actually have a poll for you guys, which I'm going to try and pop up now. While you guys keep answering that, I will hand over to Mr Shah, who's going to introduce himself and his practice and give us some insights into imaging of the knee.
Thanks, Lily. Thanks to Scan for their kind invitation to give this webinar. Thanks to Lily for her introduction. I'm a little bit conscious that you can all see me, I can't see any of you. So if I, you know, it's sometimes easier to give talks when you can see people because you can see the reaction. But as Lily mentioned, if you've got any questions at any point throughout, then please post them. It'd be great if we could make this as interactive as possible. So that's better for your, you know, your benefit really. So you can ask whatever you want as we go along. I'm, you know, I'm not, I'm new to Scan. I've been using them a couple of months and they've been fantastic. And my patients really value the ease with which, as Lily showed, the website works and how they can find a radiological site that they can get their imaging done quicker, and certainly for certain patients who are self-pay, how they can find more value for their money in and around London rather than just be stuck with the choices they're at. So I really commend Scan to you. A little bit about myself. I'm a consultant orthopedic surgeon, 12th year now, and I'm a consultant in my NHS practice based at Guy's and St Thomas's, where until just recently I was the head of department, but my term has now come to its end, so I've had to hand that over, which has been a very fun experience, a very challenging experience for the last several years where we've had COVID and all the strikes, but you know, I've thoroughly enjoyed it, and we've kept the department going and flourishing and expanded it and delivered most of what we wanted to achieve. So I'm very proud of that. My practice is mostly hips and knees, sports related as well. So particularly of the knee. I do my private practice just across the road at London Bridge, and in close to where I live in southeast London at Blackheath, and further out in Orpington. My specialist area, as I said, is in hips and knees. I did my fellowship in America in New York, which is you know, one of the great hospitals that I was at, a hospital for special surgery, which is one of the great orthopedic hospitals. I was very privileged to do my fellowship and learn about my trade as much as I could there before I came back in 2012 for appointment at Guy's. Now, the title of today's talk is knee pain and when to refer. Now, again, I should apologize. There's not many slides. In fact, there's no slides. There's just me talking to you and having some conversations with you about what and scenarios that you come across and what I would consider would be the next port of call in terms of investigations and what types of investigations we look for. But I just wanted to put a question out there. Obviously, I'm talking about knee, and knee pain is very, very common. We see it obviously a lot in our practice, but GPs, you guys, physiotherapists, osteopaths, chiropractors, GPs, sports therapists, I'm sure it takes up a lot of your practice, and you see it in all age groups, young and old, and it increases obviously as we get older. It's thought that its prevalence is about 20% in the general population, and about 13% of people registered across the country with GPs, about 13% of those on GPs' books present with knee pain per year. So it's a staggering amount of number. It's likely that that's an underestimate because obviously you don't record everybody, and certain GP practices don't have that data available yet. Now, the question I had for you guys was, there's one other more common musculoskeletal presentation, i.e., instead of knees, what other region is more prevalent or more common in terms of presenting to either you guys or the GP? Now, I don't know if we can ask that, or we can just take a poll as to say what's more common. We've got an answer from Richard here, which says shoulder, not quite. So shoulder, no. Back, yeah, Gina, back, absolutely. Spine is a little bit, I should say, much more common than knee in terms of presenting to you guys, and that's really a reflection of the bad postures and that we have as a reflection of modern society. The prevalence of knee pain, and it's increasing, is a prevalence, a reflection of the fact that we're much more common and we're much more doing lots of sports at younger ages, at older groups, we're living older, etc. Now, obviously, there's lots of areas of the knee and lots of components of the knee. So one of the ways in which knee pain may present is because of either a region within the knee. So in terms of the knee, as a surgeon, we talk about three compartments: the anterior compartment, which is just behind the kneecap, and then the medial and lateral tibiofemoral compartments. And you can present with pain on the inside, pain on the outside, pain at the front of the knee, pain at the back of the knee. And those relate likely in most scenarios to pathology, to problems that's happening in those particular regions. You can also obviously present because of underlying tissue type. So the knee has bone tissue, obviously. It has soft tissues, and soft tissues has the cartilage, the menisci, the cruciate ligaments, the collateral ligaments, the tendons, patellar tendon, quadriceps, Hoffa's fat pad. All of these things can contribute and can have things wrong with them to present with pain in the knee. And that's why we'll come on to imaging. That's why we need imaging, because there's so many components of the knee that just eyeballing it is not going to allow you to determine whether that knee on the medial side of the knee is a meniscal tear or an MCL tear or a bit of early OA or etc. You can locate the knee pain, and the history might give you indication as to what that might be, but definitive diagnosis needs imaging. Now, knee pain is actually also increasing in presentation, and I want to ask if anybody there can tell me what might be the reasons why we're seeing more and more knee pain than we did 20 years ago, 40 years ago, 60 years ago. Any answers? Let's have a look. So why do you, a more active, sedentary lifestyle, obesity, yeah, anything else? People living longer, yeah. More training, yeah. Lack of strength, weaker feet, sitting for a longer time, yeah. So these are all definite reasons as to why we're getting knee pain. And obviously you'll imagine that knee pain, depending on those reasons, will contribute to different types of age groups. So the fact that we're much more sporty and doing more sport, and maybe, you know, we were less inclined to warm up, stretch, all that kind of stuff, maybe present with earlier problems of stretching tissues, collateral sprains, ligament injuries, meniscal tears, tendinosis, runner's knee, etc., in a younger age group. And the fact that somebody's mentioned we're living longer and more active as an older group, we're obviously seeing more arthritic type of patients. And obviously obesity, we're carrying more weight as a general population. That weight has to be carried, and it has to be carried by your hips and then your knees, and knees are the biggest joints in the body, and therefore they will take most of that strain if you're overweight. And obesity is thought to be the number one driver across the whole range of why we're seeing more and more knee pain. And certainly in my practice, in the older age group, not the sporting type, although it's still a factor there if you're not quite, if you're overweight and obese, but in the older age group, the arthritic presentations, the average BMI is heading north to towards 30. It's about 27, 26, 27, which is overweight, but it's heading towards 30, which is obese, in terms of patients presenting with knee pain who then go on to have a requirement for knee surgery. And just as another question, which country in Europe do you think has the most prevalence of obesity? I mean, obviously, it's not, we're not talking about knee here, but just as a sidetrack, it's quite interesting. Which UK, UK. Yeah, Ireland from somebody. No, it is sadly our country, United Kingdom. It is has the highest prevalence of obesity across Europe, and that has a direct contribution to what we're talking about, but various other health factors as well. Okay, so we talked about knee pain, its prevalence. We talk about why it's increasing, and we talk about why there are different risk factors. So we said age, we said obesity, previous knee injury, obviously we're more sporting. Occupational health factors, as one of you mentioned, we have more knee straining work, such as kneeling, sitting down for long periods, working computers. That flexed position is not natural for the knee for a long period of time. And obviously sporting measures, and it's a particular type of sport that you see more knee pain in. It's sport where there's loading and twisting, that torsional activity. So that's particularly where tennis players, they often get sprains, collateral and meniscal tears because they load and they twist. Football injuries because they run, stop, and they turn direction. That's called cutting, and that leads to meniscal tears. And obviously the physicality of sport in terms of somebody injuring you, impacting you, also leads to increased presentations and risk factors. There are 3 other risk factors that we're seeing that are not necessarily related to age, not necessarily related to physical activity, but are actually outside of that. One is mental health. So, mental health has become, rightly so, much more of a topic over the last 20 years. It was previously, we all never really talked about it, but its risk factor and its presence in terms of making you more aware of knee pain and exacerbating that knee pain is a big factor. Social deprivation, we know knee pain is also seen much more commonly in people from poorer parts of society. And interestingly, race, South Asian ethnicity seems to have an increased prevalence of knee pain, not necessarily ACL injuries or meniscal tears or arthritis, but just knee pain in general. We don't know why that is, but those are 3 other factors that are risk factors for getting knee pain that are not obviously common sense. Another way to think about knee pain is by age. And, the likely causes at a younger population, and a middle-aged population, and in the senior parts of life. And in the senior parts, over 50, it's very easy to think what that might be. Typical degeneration, what we used to call wear and tear, or arthritis as medically known. gout and pseudo gout. That's where crystals develop sort of because of poor health, poor diet, poor hydration in big joints, particularly. Used to be commonly the big pictures in your great toe, but it's just as common in the knee. Baker's cyst, which are actually caused by meniscal tears and present as collections of fluid leaking out from the knee at the back. And then also importantly, referred pain. So a lot of people with hip arthritis present with pain in their knee. And younger age groups, let's say 18 to 50, present with degeneration, obviously, but more likely as a consequence of overactivities, sort of, running too much, not warming up or cooling down, poor posture, poor running techniques, poor shoes, increasing their level of activity, suddenly deciding on January that they're going to do a marathon this year, and not really thinking about how long that will take to prepare for, and doing it too quickly and then bringing on tendinitis and that kind of stuff. You got the ITB syndrome, with pain on the lateral aspect, again, due to running and that kind of stuff. And in the younger age group, under 18, that kind of stuff, you've got to think about chondromalacia, sort of, softening changes of the cartilage, particularly behind the kneecap. Osgood-Schlatter's disease, where the tibial tuberosity doesn't quite unite, and therefore leads to increased inflammatory, particularly after running. We talked about referred pain. Now, in the younger age group, under 18, you've got to be conscious of two conditions called Perthes and SUFI, which are actually conditions of the hip, but in that adolescent type age group present with problems of the knee. And I remember one of the first cases I ever came across when I started orthopedic training was a 13-year-old young boy, obese, typical risk factors, who was investigated for knee pain for almost like 6-9 months, because that's what he was complaining of. But all his investigations of his knee were all normal. And we then investigated, he was referred to us, and we said, well, hold on, let's have a look at his hips. And lo and behold, he had slipped upper femoral epiphysis, which is where the top of the femoral head just slips off because it hasn't united. And that was what was causing for all this time, all his knee pain. So you've got to be conscious of that fact that hip pain can present in knee pain. And then you've got other things, a bit of hypermobility, osteochondritis dissecans, where a bit of cartilage and bone fall off the femoral condyle. And then there's conditions which you've got to be aware of because they're so, they're red flag, as it were. One is sepsis, infection knee, septic knee, which is something that you've got to act quickly on, because the longer that sepsis is in the knee, the more damage it's going to go to the cartilage. And then if it destroys the cartilage, you can't grow that back, and you're looking at an arthritic knee, and then that's going to lead to early need for intervention such as a knee replacement. So if you suspect that, then obviously refer to A&E ASAP. And that's usually a red, hot, swollen, pain knee that's come on very, very suddenly. And then the other thing is tumors. If things just doesn't sound right, and they're getting pain and it just doesn't feel right, and it looks okay, but it's come out of nowhere, then the other thing to bear in mind are tumors and metastases in the old age group. And so again, that's a quick referral for further investigations. Now, all of that is background. Obviously, what we want to know is investigations. And in terms of imaging, there's a sort of stepwise level of imaging. So there's X-ray, there's ultrasound, and then there's the two big ones, the CT and the MRI. Those are the sort of four major types of investigation. You've got various other CT scans, PET scans, but those are the main ones that we would use for investigating and treatment of knee pain. So I'm going to have a little pause there and just say, of what I've talked about so far, is there any questions, anything that anybody's got that they want to clarify or just bring up or ask again, or to go over anything, while I then go on to talk about these other modalities and when we would use them. And then this next section will be fairly quick, and then we can go on to straight away cases that you have, or questions or scenarios that you guys have that you'd like to ask me. What would you do, or what's the next question? What's the next investigation? Yeah, so there's a question about the question is, I mentioned a link with mental health. Absolutely. There is, you know, as I said, mental health is becoming more and more acknowledged, and it's always been like an iceberg. We've always thought it's there, but actually its true prevalence is massively underdiagnosed. And part of the problem with that is the means to diagnose. It's not a simple test like an x-ray you take, oh yeah, you've got mental health issues. And part of it is also people coming forward and expressing themselves and then seeing specialists in that area. But we know amongst that group, they have an increased prevalence of pain and increased susceptibility or sensitivity, I should say, to pain. So whereas somebody may have some, you know, may go running and they may develop a little bit of knee pain, and then they brush it off 2-3 days later, it's all okay. Somebody with underlying mental health issues, and it's a linear thing, so the more mental health issues you have, the more it will affect you, is that their level of that knee pain will be greater. And the length of time it takes for that to settle will be longer. So now what the mechanisms of that are, I don't know. But in simple terms, the way I think about it is that you're more sensitive because your brain is, your mental health and your well-being is not quite even, it's not quite balanced. You're much more sensitive to any changes and any messages you're getting from any part of your brain, any part of your body saying, hey, I'm in pain, I'm in pain. So you're much more receptive and sensitive to that. So it becomes a heightened awareness. So whereas most people would have pain 1 to 2 and they wouldn't think anything out of it, in a scale of 10, they just carry on. But in somebody with underlying mental health issues, that 1 to 2 may actually be 3 to 4 or 4 to 5. So they actually are more cognizant and therefore more aware of that pain. I can send you the link for I've asked if there's an evidence for that link. I can send you it. One of the things about evidence, obviously, is that, you know, all of these have come out of trials and studies and things like that, and trials and studies and everything are only based as good as the data they have and the evidence at the time. And so time will tell the strength of that evidence, but it is emerging with these studies that there is more a correlation between the two. So, you know, I'll send a link to Scan and they can put that out to everybody for the link for that. Is the knee pain that leads to worse mental health, or mental health creates the sensitivity? You know, I think it's the latter. Clearly, if you're in any type of pain, you're not overall in well-being, are you? But I'm not talking about that level of mental health. I'm talking about, you know, if you have underlying mental health disorders of depression, of high states of anxiety, that kind of mental health, rather than, you know, just upset about something. I'm talking about real, actually, diagnosis of depression, let's say, of being on drugs for depression or anxiety or taking drugs for anxiety. Those kind of things heightened your sensitivity to then having knee pain or sprains of your knee, which then you're a lot more aware of or seek treatment for. I guess a depressed person I don't know the rest of that, but yeah, absolutely, somebody with depression and anxiety, those kind of things, as I said, they become more sensitive to pain. You know, one of the things I see in my city practice, because there's a lot of people from the city that we see who are actually, it was quite a surprise to me when you take their medical history. They're on antidepressants, anti-anxiety, and they present with knee pain. And just anecdotally, from my experience, a lot of them are on these medications. Although you wouldn't frankly say they were depressed, they didn't appear depressed, but they were on medications for it. And a lot of them had knee pain. And when we investigated them with either an MRI scan, there wasn't really much going on. They didn't have a frank tear of anything or degenerative changes or anything that was massive pathology. They just had a bit of sprain here, a bit of stretching here. But I think they were more sensitive to it because they were on and that's my anecdotal experience. I've not published that, but I think there is and also, yeah, you're right. Michael here says that a depressed person may exercise less and maybe in less physical, better health. Absolutely. Is there any other questions from what we've talked about? Otherwise, we can just move on to talk about X-rays and ultrasound and MRIs.
Mr. Shah, we've got a hand raised, so I'm going to see
Yeah.
if I can unmute Rose, who has a question for you.
Yeah.
Rose, you should have.
Sorry, I actually clicked that by accident.
No,
Sorry.
That's
well,
all
if
right.
anyone has a question that they would like to ask over voice, do feel free to raise your hand, and then I can flag and unmute you.
Okay, we've got another question here from George. Hope nobody minds me using their first name. And he asks, do you see many patients with knee pain and vitamin D deficiency? That's a really good question. The answer is that I don't know, because we don't measure vitamin D. I see a lot of knee patients with a lot of knee pain, but to be honest with you, vitamin D isn't something that we would investigate as a surgeon. I suppose I should do, really, if they come back and they've got normal examination, normal imaging, and we say to them that, look, your knee pain is maybe functional rather than structural. There's nothing structurally wrong with your knee. It may be that you're just running too much. You need to change your trainers, or you're not warming up enough, or your musculature, or your knee's not balanced. All of these things, and then we refer them back to their GP or their referrers. We don't tend to, as orthopedic surgeons, measure their vitamin D levels, but and you may be alluding to this, we know that vitamin D is very important to musculoskeletal health. And so it's entirely possible that a vitamin D deficiency could lead to problems with the musculoskeletal system. Now, whether that's because of, the metabolic systems, and whether that's because calcium metabolism and all the rest of it may lead to bone pain, or may lead to reduced healing potential, etc., etc. I don't know, but vitamin D and its deficiency has been implicated in a lot of lethargy and various other physical ailments, and a contributing factor in various other things. And it may well be that knee pain, and any musculoskeletal pain, I suppose, for which we can't find an obvious reason, like we've investigated in, let's say, for the knee with an MRI scan, there's no meniscal tear, ACL, PCL are good, collaterals are good. There's, you're looking at a pristine knee on the MRI, other than a bit of inflammatory changes here and there. Then I suppose it could, if they were to be vitamin D deficient, then I suppose it would be possible that that's the cause. And obviously the proof would be that if they take the supplements and get their vitamin D back up to level, and their symptoms go, then there's your proof. But often what happens is that not only if they are vitamin D deficient, they may then change their exercise regime, they may change their physiotherapy, they may see a different osteopath, they may change their trainers, they may start to warm up, they may do all of that as well as take the vitamin D, and then their symptoms get better, and you're not quite sure, well, is it because of the vitamin D, or is it because of all the measures they did after seeing you? And the other thing just to be aware of is that it's said that up to a third of patients in this country, because we see very little sunshine, are vitamin D deficient. And certainly in my community, the Asian community, that's even higher. 40-50% are said to be vitamin deficient. Now, not all of those have knee pain or musculoskeletal pain. So I think it's not a direct correlation. I think there's several other factors that are going to play a part in this, but it's certainly an interesting question. And if the only thing you have is vitamin D deficiency and everything else is fine, then it's worthwhile. It's certainly worthwhile taking supplements to try and get that up to normal. Yeah.
Mr. Shah, before we move on to the imaging section of your talk, I was wondering if we could run another poll just of the audience to find out how often they refer for imaging.
Yeah.
as sometimes it can be useful to understand, you know, how big a role of imaging
Yeah.
practice.
Absolutely.
So this
Absolutely.
should be up on their screens right now, and then I'll be able to share the results with you after, so we can see.
Sure. Yeah. That's
What
good.
the most common is a few times a month, fairly often at the moment.
But is that because some of our participants don't have access to imaging, or the imaging they want, they can't? You know, some physiotherapists, some osteopaths, some sports therapists, they can't ordinarily refer for an MRI scan. You need a doctor or somebody approved, should we say, to refer for that. So that might be a limiting factor. But I mean, in my practice, I not the NHS, but in privately, I see as a ballpark, over 100 patients a month, let's say. Almost all of them, in fact, absolutely all of them, unless they come with imaging, will have imaging. And nowadays, you know, particularly with the medical legal aspects of things, we have an increasingly litigious patient group, and so you can't just say, yeah, you're okay, off you go, there's nothing wrong. You have to have evidence for that, and the evidence is based in imaging, and so you have to have that backup. So I think there'll come a point where you know, all of us who see patients will have to have imaging to back up what we clinically find, because clinically is not defensible in a court. You need imaging to back it up, unfortunately. So I think the poll there suggests that it's a few times a month to the only people above that are 7%. And I suspect that that's probably more about access and means of access rather than whether they want it or not, you know.
Yeah. There's also a couple of comments in the chat about access to imaging and how to find where to get it done, and also GPs being reluctant to consent. And it is worth mentioning, a small plug from my side, but when referring with scan.com, you actually get some input from our clinical team, who are all experienced referrers, GPs, radiologists, etc. So there's that kind of extra safety net of due diligence. So in terms of access, you know, that's one thing that we're really big on.
Yeah, I think I would expand on that, Lily, and you know, Michael's asked about, you know, it's to do with access and where we can get this locally, and that's one of the beauties of scan. You know, it's one of the beauties of all of these things when they come along, and you think, well, why hasn't anybody done this before, kind of thing. And scan allows you, when you go on and input the data that it asks, to tell you where, you know, you can get that MRI of your knee in your local vicinity, and what the waiting times are next week, 2 weeks, a month from now, and the price. So all of that information is very useful, because you can then be able to see very easily where it's available, and the waiting times and the cost. The other thing somebody mentioned here, most GPs are reluctant to consent to referral to MRI imaging. I think that's right, and I think it's fair to say that, you know, primary care, they probably stop at an X-ray. They can get an X-ray fairly quickly, fairly easily, but anything beyond that, ultrasound here and there, but a CT, MRI scan, anything beyond that, the GPs usually say, well, go and see a specialist, because, you know, they can tell you whether you need an MRI or CT, or what type of MRI, or what region, or what to focus on, etc., etc. So part of that is proper responsibility of saying, well, look, I might get an MRI, but I'm not the specialist in this area, so let's get you seen by a specialist, and they can do it from there. Yeah, absolutely. Someone mentioned about the GPs not being so helpful in not being so helpful, but not having the means and the ways to arrange for these specialist tests. Somebody mentioned about the cost of maybe a limiting considering. Absolutely, you know, MRIs are not expensive, but again, plugging for scan, and I'm not, you know, I don't want anybody to think I'm some you know, paid member of scan. I'm not. I'm just telling you that their website allows you to see the cost, and it's incredible, actually, because it reveals to you what those of us who work in central London and outside London know, that, you know, sometimes the cost difference between a scan in a central London facility versus just on the periphery of London can be an order of three in terms of price difference, and patients aren't aware of that. Sometimes clinicians and ordering individuals aren't aware of that, but it's all available there on scan. NHS imaging, yeah, it is gold dust because it is easily available and it's free for everybody, and you can get it fairly quickly. Is it possible, somebody says, is it possible, if possible, make use of the ESP surface locally? I think that's probably more one for you, Lily. I don't know ESP service. I don't know ESP extended scope practitioner. Is that right? Yeah.
I think it's physios, yeah.
Yeah. I absolutely agree with that. Private imaging is very accessible, but NHS access is very limited for patients. I think that's a good point. I think the NHS's imaging is available. You can get all types of imaging apart from the highly specialized cancer type imaging on the NHS. There's a pathway for it. That's the problem, because it's rationed, because it's paid for by the taxpayers, by the people. So it has to be rationed so that people get it according to need. And the gatekeepers of that are, if you like, the specialists and the secondary care practitioners, the hospital practitioners, and et cetera, et cetera. And to get to us, to get to the imaging, you need to go through your GP to be referred in, to us to see you. So yeah, it takes a while. Whereas, like you say, privately, it's very easy. You go and see a specialist, or you go directly if you can.
We've got a lot of people in our poll results saying that the wait for the NHS MRI in that area is more than 12 weeks.
Yeah, I mean, that's shocking, really. One of the shocking things about that is that, if you're going to say that's 3 months to get a scan, and then it's probably another couple of months to go back and see the specialist, or see you guys or see us, that's a long time between when they've presented, when they've had the problem, and then when they found out what the problem is, and then to start the treatment for that problem. So it's not great, and it highlights why getting access, if you can, to privately, if you can, to an MRI scan or more quickly is so valuable. When on to see a consultant, they tend to also prefer an arthroscopy to an MRI. I think that may have been true back in the day, that surgeons were quicker to do an arthroscopy than an MRI, but I think that's no longer the case. I mean, to do arthroscopy is a surgical procedure, and you often have to justify now why you're doing that. And you can't justify it without imaging to say it's a meniscal tear or an ACL, because that is one of the checks that we do when we do an operation, is we do a surgical checklist. And one of the main criteria of that is imaging being done, and what does it show? And increasingly now you have hospitals, including in the private sector, where you have MDTs who are multidisciplinary teams that, if you like, triage or filter what surgeons are doing in their lists. And then, back in the day, that wasn't that. So you could just list everybody for a scope and do them and make a killing in terms of financially, and nobody would know about it. But now every case that we list is vetted, is triaged, is filtered to say, is this appropriate or not? Because you have to do it at a private hospital. It's not Mr Shah's facility, it's London Bridge Hospital. And they don't want any, they don't want anything to come back at them for doing illegal practice, shall we say, or not professional practice on patients. So you can't do that anymore. You will have to get an imaging. Yes, we're better at writing letters and emailing them to GPs. MSc request imaging. Helpful extended program there. Just MSc. Yeah, meant to say when one season they prefer arthroscopy. This is probably because some GPs prefer paying for MRI too much. Yeah, I think all of these things cost, and NHS has to budget, and GPs have a budget, hospitals have a budget, and the way to try and make sure that the right patient gets the right scan is for specialists to see them, which I think is why most GPs will not get an MRI because it's expensive. It takes out of their budget for their practice, and they'd rather transfer that to a specialist, and the specialist can get it at their center or at their hospital, etc. Are you happy to use MRI report to assess a patient if done independently of a consultation with you? Consider some consultants prefer to arrange that. No, that's a good question. it's a good question, because imaging is only as good as the report, as the person interpreting it. You can have a fantastic image, but if the guy who's looking at it doesn't see the tear, doesn't see the ramp lesion, doesn't see the small fracture, then it doesn't mean anything. So imaging is good, but it has to be reported by somebody good, and you have to have, me as a surgeon, has to have trust in them. So when I started out, I didn't have that much experience looking at images, because that's not my background. I'm a surgeon. I had more experience of doing it. But now, 10 years plus in practice, I've seen a lot of images, and oftentimes, although less often now, but oftentimes we would see them, the patient, before we get the report. So we would have seen them, taken their history, got an examination, and then correlated that with the imaging before we'd got an expert radiologist to report them. So we'd come up with our own, oh yeah, I think that's a meniscal tear, I think that's a tendinopathy, I think that's an OCD, I think that's that. And then we'd get that reassured or corrected or modified when we'd got the expert radiologist to provide us with a report. So 10 years of that has allowed me to become fairly okay. I wouldn't say I'm a radiologist, but I'd say I'm fairly confident in interpreting images, including MRI scans. And so I'm fairly good at looking at images. So if somebody comes to me and have had their imaging elsewhere, as long as I can see the imaging, it doesn't need to be reported by somebody that I work with, as long as they've got a report. But as long as I can see the imaging, I need to see the imaging, because oftentimes, and this is something I hope SCAN takes on board, is that when they produce a report, somebody can say, oh, there's a tear of the meniscus, right? And that's all they could put in the report. But actually, somebody else could say, well, there's a radial tear, or there's a bucket handle tear, or there's a tear in the peripheral third, or it's of 20 millimeters length, and this, and this, that. Gives you a more visual idea. But if somebody just says there's a tear, is it a small tear, is it a big tear, etc., etc.? So that's why you need to see the images as a surgeon. And I wouldn't recommend to any surgeon or to any patient for them to proceed with surgery just based on the wording of a report. The surgeon should see the image, and it would be negligent of a surgeon to operate without seeing the images. They don't necessarily have to be done at his hospital, but he should, or she should, see the images so that they can actually say, well, I'm confident that that report is an accurate representation of those images, and therefore I go with this. You can't just go on the report, and you can't just go on the image, but the two of them you should have together. And about arranging the MRI scan, I think most of us would repeat it if there's been a length of time. So if somebody came to me with an MRI scan from another center and said, look, doc, it showed that I had an ACL tear, and I want you to give me an opinion. If it's within 6 months, then I think you can go with that. And if nothing's really changed in their symptoms, i.e. they've not dramatically changed, they've just stayed with them, then I would think most of us wouldn't repeat the images. But if it's been over 6 months, or there's been a dramatic increase or a step change in their symptoms, or worsening, or they've heard something different, then I think it would be prudent to repeat the images. And certainly if it's the MRI or the image was from 2 years back, then I think all of us would repeat the images to get more up to date. And my particular cutoff is just 6 months. So, but there's context to that. In our area, the GPs won't refer directly for NHS scan, but refer to MSK. Yeah, that's perfectly fine. I think you're right. I don't think it's just. I think that's going to be a national thing. They'll offload that work, that decision making, to MSK specialists like physios or ESPs or chiropractors or whoever they work with, to say, well, this is your particular field. Have a look at this patient, and then you guys, if you decide to refer or get imaging, then that's on you rather than the GP, and the GP saves time and saves their budget. So current wait times for that are up to 6 months. So as an osteopath, I'm referring privately some more. Some GPs are requesting justifications for referral, even for an X-ray. Yeah, I mean, that's what can I say to that? I don't think that's a good thing. I think if you as a professional colleague have seen somebody and you feel that they need an image, then you should have the means to that. You should have the access to that, and something simple as an X-ray, providing patients and everybody's taught about it and the risks and all that kind of stuff, and pregnancy and all that kind of stuff, then I don't think there should be that kind of a control over getting these images. What is the medical legal status of the MRI report? Well, what I meant by that is that if you are going to, if it becomes a medical legal case and you've acted or done something without appropriate imaging, then you will be found to be not doing something which your peers would do. And the Boland test is, if you're negligent, if a body of your peers, so for me that would be other orthopedic knee consultants. If you're a physiotherapist, that would be other if a majority of them would say, well, actually we would get an MRI before we would do this, then you have acted negligently, because your peers would have done something different and you haven't done that. So that's what I was saying, that as a surgeon, I would consider it negligent if you operate without imaging. Now, where that imaging comes from, which was the original question, is up to you whether you trust them, whether you believe in them, whether you have relationship with them. That's up to you. But to have no imaging at all, it would be considered negligent if you then proceed to say, well, I'm going to do a knee arthroscopy. Have you done an MRI scan? No, I just think they've got a meniscal tear. Then if something happens and the patient then sues you or sues the hospital, then you haven't, forgive the pun, you haven't got a leg to stand on, because you haven't got any imaging to prove that there was a pathology for which you needed to do the scope. So that's what I was saying was the medical legal status of the MRI. And an imaging is an image. You need somebody expert to report that. That's a radiologist, and you need a surgeon expert to then put those two together in the context of the patient, because the radiologist won't have seen the patient, won't have examined them, etc. So you need the image, you need the radiologist report, you need the surgeon around the patient to say, this is the next step for you. I think this is about GP surgeries and how they're moving towards MSK. So that's a good bunch of questions. Keep them coming. I'm happy to answer any particular case scenarios. I mean, the next part of my talk was really just a very superficial thing about talking about X-rays. Does anybody know about the Ottawa knee rules about referring for an X-ray? Oh, okay, sorry. So go back to here. I think James was saying that what he meant was that to what extent can reliance be made on the report per se? Well, that's what that goes to the heart of what any of us do, isn't it? To what extent can you rely on me? Well, you say he's a surgeon, he's got 10, 15 years as a consultant, he's at Guy's and St. Thomas's, he's got this qualifications, he works this, his reviews are this, his reputation is this. You go and trust. And it's the same for me. I know the radiologists that I work with. I've built a relationship with them. I refer my patients to them. They give me the report. I know what they're, I trust them. And that's not that I don't trust others. It's just that I've got a relationship with them. And then I know from my experience now how to interpret images in the way I have. And I suppose the question is, you have to have trust at some point that the person that is giving that report is doing their job properly, and that comes on experience and relationships. So, the question about what reliance can be made on the report will be dependent upon who's doing the report and how much me as a surgeon relies on that person, on their interpretation of that image. Now, there's been times, and I'll be transparent, there's been times when I've seen a report and it's just not fitted in with my examination and history taken from the patient, and I thought this doesn't match, what he's telling me and what I've seen. And I've gone to the imaging myself and gone through it, not properly, but gone through it a bit more meticulously and a bit more thoroughly. And I've then come to realize, well, actually, that report is not doing as justice as much as I would to that image, and it's missed a few, and it's not relying on this. And what can you do? You say thanks very much, and you interpret it based on what I think, and then you the relationship, you don't refer to that person anymore. You ask for another radiologist to interpret those images. So, you know, that does happen, that you don't go on the report, but that comes down to my, if you like, skill as a surgeon and interpreting the image and the report and putting it together with what I've seen of the patient, what I've done on examining, and my own personal experience of however many years it is. Another comment here, maybe the chiropractors, osteopaths and physios should band together and lobby for the NHS re-referral to consultants on for imaging, as where I live, it's an appalling situation. Yeah, I mean, I think that there's, you know, that is possible, but I certainly know that some physios do have the potential of referring to for an MRI scan. I'm not sure how that is, but I certainly know I get referrals from some of my local physios, and oftentimes they've already got them an MRI scan. So I think that's happening. Now, whether the idea is to band together and get it, I'm not sure about that. I don't know what the legality of that is and what the national bodies would say about that. But I think it's coming. I think there'll come a point, you know, with the we were talking about this earlier, Lily and I, about the technology and how that's, you know, driving a lot of the changes that are coming in healthcare and the ease of use, the apps, all that kind of. I think imaging is going to be the next big thing, and I was saying that it's just a matter of time before in supermarkets or in shopping malls you have little photo booths or such forth, that patients can just go in there and, you know, key in their symptoms or what they're worried about, and an AI model will tell them that you need a scan, and, you know, press this button, pay this amount, and bingo, we'll do the scan for you within that photo booth or within a larger booth, and they'll go home at the end of their shopping with a scan and a report as to why they're getting knee pain. So these changes are going to come, and technology is going to drive a lot of that. Yeah, I mean, I think I share some viewer mentioned about how frustrating it is that you know you have to go through these loops to get these images, and I share that frustration. I suppose the people who control this would say that, you know, it's a means of quality control, and it's a means of safety check, and it's a means of not, you know, getting them, because I suppose for a lot of them, you would argue that you need these filters, you need these loops to go through, because otherwise everybody would just go to the most definitive investigation, which is a CT or an MRI scan, and skip the X-ray and skip the ultrasound, and that leads to various cost implications, radiation with CT, etc., etc. It's a shame that there isn't a system like scan.com for the NHS so that we can recruit. Well, you know, who's that? Gina, that's a great idea. You know, Scam, they may become so amazing and brilliant that the NHS enters partnership with them. And I think that, you know, the powers that be at Scan should reach out to the NHS and say, look, because what this alludes to is that waiting times are different within the NHS and different parts of the country. And obviously NHS doesn't have pricing, but it does have waiting times. And in my hospital, the waiting time to get a scan may be a month or two, but I don't know, a hospital in Norwich or near there, maybe half that time. So if you even out these variances, the waiting times here are much bigger than here, then that's better. Obviously, there's transport questions and everything, but that's something definitely to think about. And I think the technology will allow that. And Scan is, I think, at the forefront of trying to, you know, reduce those variances. Access again. And again about referrals. So if we refer to private MRI and a joint replacement is needed, how long does it take for referral to NHS? Paying for a scan as well, but paying for a joint. Yeah. The first thing I would say to you about that is that MRI is a very good investigative, diagnostic, radiological tool, absolutely. And it will confirm to you degenerative changes, osteoarthritis. But almost, again, actually every surgeon who does a joint replacement will want a baseline X-ray. So even if you have an MRI scan, you get it, and it's reported and shown, look, they've got a worn out joint, grade 4 cartilage damage in all 3 compartments, and bone edema and osteophytes and all the rest of it, deformity, varus alignment, all that, and you come and say, you refer it, let's say, to me, and I see them and I examine them and I see the MRI scan, I will still get an X-ray to do the operation. Why? Because because it's a bony procedure, isn't it? The joint replacement, we're cutting bones, and an MRI, whilst you can see the bones, it gets clouded out. There's a lot of noise in an MRI scan. In the X-ray, it's just the bones, the alignment, where the joint spaces are. And as joint surgeons, we will go back to an X-ray in every case, even if they've had an MRI scan. A CT is better than an MRI and an X-ray if you're going to do joint replacement, but it's only there for certain cases where you need some extra information and extra detailed analysis of anatomy to reconstruct it. For 80 to 90% of cases, if not more, an X-ray is all you need prior to planning their surgery. So how long does it take for referral to NHS? Well, that will depend on where you are. So if you've confirmed that they've got an arthritic joint and you think the next stage for them is a joint replacement, and so you're going to refer to them, then that referral will, as many of you have alluded to, either go to the GP to referral or go to MSK services at the hospital, which will then filter it to then come to us. And that can be anything from within 6 weeks to 6 months, depending on individual hospitals and their department waiting times, et cetera, and it's not great. And COVID hasn't helped, obviously, and the strikes haven't helped either, and et cetera, and that's why there's a big waiting time to get to see us, and then a big waiting time from seeing us to have your operation. Not going to be self-referred to him, but the wait for that is, so it's not good. If the patient can afford to pay, then it's easier, but most of them can't afford that. It sucks. Yeah, I mean, I think that the state of the NHS is, for those of us who deal with it, work in it, and employed in it, it's far from great, to put it mildly. It's a shame, because it's a fantastic thing when you think about having a free at the point of access, although we all pay for it for taxes, but at the point we need it, there's an NHS there. The problem is the timing, the facilities, the investment, all of that has led to an NHS system that is now struggling. Many people have described it as being in ITU itself and being towards the end of its life, and which would be, if we lost the NHS, it would be a massive shame, because if you travel around the world and you see other healthcare systems, you'll appreciate the fact that, for example, I spent some of my training in America, and one of the first things, if not the first thing, that was asked of patients when they came is, who's paying for this? And if you didn't have means of paying for it, then you were sent to a veterans hospital or somewhere where they would give you that free. But those hospitals are very, very underinvested, and they're just as bad as our worst NHS hospitals. So that's not a great system when the person is at their most vulnerable healthcare wise, and the first question they're asked is, who's paying for this? And if you haven't got the means, then you're going to go elsewhere. Our system, which is, you can go to see your GP, you can go to see your A&E, you can go to the hospital, and you don't have to worry about who's paying for it because it's paid through taxes. It's a fantastic system. The problem is that we haven't looked after it. That could include investment, staffing levels, training levels, infrastructure, the models of how we do it. We haven't looked after it, and now it's at a point where it's really, really creaking, and bits are falling apart, and we're all seeing that from people like myself, surgeons who work in it, to people on its fringes, people who refer into it, people who have to deal with it, patients. We're all seeing that. So I echo the concerns about that NHS. Is chondrocalcinosis responsible to cause knee pain, and how is it treated? Yeah, I mean, that's a good question. Usually you see that if it's really bad on an X-ray, you can see the calcification of the cartilage or the calcification of the menisci. You can see those calcified shadows on the imaging. Is it responsible for knee pain? Yeah, I suppose, everything is in context. If you've got a patient with pain and you examine them, and then you get a history, and then you get a history, then get examined, then you get the imaging, and the only thing you found is chondrocalcinosis, then it's possible to surmise that that calcification of that tissue causes thickening. Calcium will cause thickening, like furring of like limescale on your kettle or on your pipes or things like that. It makes that tissue stiffer. And cartilage and meniscus and other tissues which get calcium deposits become intrinsically stiffer. And if they're stiffer, they're less able to deal with motion and movement. And therefore, they put more strain on the muscles and other tissues. Hence, you get the knee pain. The second part of that is, how is it treated? Well, it's very difficult. Physio is a big part of it. Activity is a big part of it. Weight loss, all of those will help. But ultimately, if it's a calcified cartilage, you can't really do much about that. You can't really remove the cartilage. If it's calcified meniscus, if you think that's a problem, you can, in some occasions, you can remove that bit of calcified meniscus, but often it's at a part of the meniscus that you can't get at and you can't reach easily. So the process of doing it is actually more invasive and more damage to the knee than actually just trying to find some way of managing that with pain relief, exercise, physio, activity modification, all that kind of stuff. Can have injections, either steroids or hyaluronic acid injections, which may help with that kind of pain. But other than that, it's not really easy to deal with. And one of the theories about chondrocalcinosis is that it's just one of the early and one of the different pathways of arthritis. So it's very hard to treat. Somebody mentioned about the Ottoman scale that you mentioned. It's not the Ottoman scale, it's the Ottawa rules. And I think you've got a response there in the chat by Anup, which is for when to refer for an x-ray, when to get an x-ray based on, in this context, knee, but also ankle. And you can easily look it up. But basically, essentially, if you suspect, if somebody presents with knee pain and you want to know, should I get an x-ray, then according to the Ottawa knee rule, then if they've got any of the findings that they suggest, then you should get an x-ray. And that is, they can't weight bear, and they can't do about 4 steps. They can't transfer from one side to the other. They can't bend their knee to 90 degrees. They've got some bony, reproducible, specific tenderness, particularly around the sort of fibular head. And if they've got bony tenderness elsewhere, like the patella, and if they're older than 55. So if you've got any of those features, then Ottawa knee rules suggest that you should get an x-ray. Now, it's come from studies to show that with any of those factors, then it's more beneficial to get an x-ray than not, because you run the risk, if you don't, of missing a fracture. And because it's a knee rule, it's there in black and white, it's validated, it's presented, it's in the literature. If you don't do that, and somebody's then, you don't get an x-ray, and then somebody does find out that they've got a problem and they sue you, the fact that you haven't acted on Ottawa knee rules, the lawyers will quote these, or the medical legal experts will quote these rules and say, well, you haven't done that, so therefore you're negligent, because that's an established rule. So these are, rules just to have be aware of at the very least, because it's there to protect you, and also obviously beneficial to the patient to rule out who needs an x-ray and to not make sure we don't miss out on underlying fractures. But it's also to protect you, to make sure you follow the rules, same with NICE guidelines and things like that.
Mr Shah, I'm just aware we're slightly
we've just gone over,
but I mean, I'm happy to stick around if you had any thoughts on the last question we've got from Mark Salmons about different types of image that you use for different circumstances.
Absolutely. I mean, that would probably be a good question to end and summarize what I was going to talk about anyway. So I think, if you're thinking of in simple terms, because obviously this will depend on the patient, their presentation, what they're presenting with, their examining findings. But in simple terms, if you think it's a bony injury, an x-ray is the best. If you think it's a soft tissue injury, an MRI is the best. And look, if they come in walking and they're able to stand, then it's unlikely to be a fracture. And so, it's more beneficial to get an MRI. If they come in and they're elderly, like we said, over 50 years old, maybe even more, and it's clear that their leg is, their knee is in varus alignment, which is like bow-legged, or they've got knock knees, which is like valgus alignment, and the knee is very bony, swollen, bony deformity, then that's more likely arthritic. And so it's more likely to get an X-ray to look at the joint spaces, to look at the osteophytes, to look at the eye alignment. If you think it's, you know, a soft tissue thing, whether that's meniscus, whether that's tendonitis, whether that's a cruciate ligament injury, and that may be obvious from their history because they tell you it happened while they were playing sport, and you know they feel a click inside their knee or something gives way, etc. Then you're edging more towards a MRI scan. And that kind of rule of thumb will serve you right in the vast majority. CT and ultrasound are for certain specialist areas. So we use CT when we're looking at planning certain difficult surgeries to look at the bony and 3D analysis and spin the image around and etc. And ultrasound is, if you know, it's very easy to use ultrasound. Obviously, you can go on a course and learn to use it yourself, and you can do it in clinic, and it's very quick, and you can use it for guided injections into certain areas, or look at superficial tissues like quadriceps or patellar tendon or MCL or Baker's cyst, because they're very easy to visualize superficially. And it's very easy accessible. The ultrasound can be done, you know, there in clinic. So general rule: bony type of thing, X-ray; soft tissue type of thing, MRI; ultrasound for superficial tissues, and a CT for more specialist areas. I mean, is that all right? Mark asked the question if he's okay with that, or if he's got any specific question I can specific answer, or okay, great. All right, well, I think as you rightly say, we've gone on over an hour, but I hope that was useful. I'll try and send out the reference for that mental health thing to everybody, and then Lily she'll have I'm sure she'll have everybody's email so she can forward.
Yeah.
Anybody's got any further questions, obviously you can reach out to me, and I'll be happy to answer them. You know, you can easily find me on the web, my office, and my secretary's details. So we're happy to answer any questions. And you know, if you've got cases, even if you don't think they need referral, but you just want to discuss them and get an idea, should I, shouldn't I, should I this, then by all means just reach out, email my office, and I'll be happy to answer them.
Right. Well, thank you very much for your time this evening, Mr. Shah. Lots of thank yous in the chat for you as well. And yes, we do have a Facebook page. We're on socials all over the place. I'll add links to where you can find us and where you can find Mr. Shah in the follow-up email, along with any links and also resources. And also thanks to everyone for attending who had such great questions throughout. It's been a really engaging session.
Very good.
It's always made better by you guys being involved as well. So a big thank you to everyone. And I'll call it there. Thanks again, Mr. Shah, for joining us this evening.
Thanks, everyone. Yeah, you will get a CPD certificate. I think Scan will send that out to you. But yes. Yeah, thanks again. Thanks, Lily. Thanks, Scan. And thanks to all of you for joining us on a cold winter's night.